While you're doing that, I'll give a few introductory comments about tox. The first thing I'll say is I'm not a toxicologist, and that's good. You don't want a toxicologist up here teaching you this because they teach it in too much detail. The second thing I'll say about tox, if any of you have taken the peer exams, and I can't remember whether it's 7 or 8, one of them has like 24 really hard tox questions. And you might think, Jesus, I'm going to flunk this thing. They will not be that hard, right? There's a whole board that creates toxicology exam questions for toxicologists. For you mortal emergency physicians who are regular docs in the ER, the tox questions will be much more straightforward than that. They'll be pretty to the point and squared up because they should save the hard questions for the toxicologists, and they will. The third thing I'll say is because of that, all of those things, a brief review of tox, we've got a couple hours here, really should do it if you're preparing for a test. There's a couple pages that we're going to look at in the slides here that are worth sort of going over again and maybe packing them into short-term memory kind of stuff. But really, just a quick review ought to really do it because they can't make the test all about this because there's a boarded subspecialty on it. All right, with that as intro, we're going to talk about tox. And let me say one other thing about tox. And there's got to be a couple toxicologists in here somewhere. There you go. Don't take this the wrong way. You could be, and I took poison call for the LA County Poison Center, mostly bites and stings for a decade, but don't take it the wrong way. Tox is one, it has no literature really, right? There's the Poison Center reports. You can't do studies because even the animal studies are different. There's different metabolism. So there's no real literature. It's a whole specialty based on case reports. So there's no science. There's all kinds of great biochemistry. It's fascinating shit. The second thing is, if you were the best toxicologist in the world, you wouldn't save many people. Let's just talk about tox and people who are poisoned who come to the emergency room. Of people who come to the emergency room intoxicated with something, and that includes all the stuff, alcohol, Tylenol, all that stuff, 99% of them live with basic supportive care. All stuff you know how to do. They're not breathing, well, maybe you should breathe for them. Pressure's low, give some fluids and a pressor. So good supportive care is the hallmark of most toxicology. And where there are antidotes and specific shit to be done that the genius Houdini of the toxicologist would bring to the table, for the 1% that are going to die, who arrived alive in an emergency room, the best toxicologist could only save maybe half because the drugs had a head start. You can't stop the process that's already started. So toxicologists can't save that many lives. It's great science, great biochemistry rather. It's fascinating stuff, but it's of limited importance overall if you know how to do supportive care. So let's dive in. Principles, this lecture, let me just give a quick overview. We're going to do some intro stuff. Then we're going to do the toxidromes. There are a few toxidromes. Those are really important because if you're going to ask a non-toxicologist a question, you'd like to be clinically obvious. So give some clinically obvious shit. Those are called toxidromes. And then the last part of the lecture, we're going to go from A to Z and talk about various drugs you might encounter, trying to emphasize the ones that are most important. All right. What are the principles you'd like to reduce exposure? What's the problems with reducing exposures? A lot of people who are seen by toxicologists are like suicidal and stuff. They intentionally are going around your attempts to reduce exposure by exposing themselves. You'd like to reduce absorption when you can, and we'll talk about charcoal and all that. Increase elimination, get it metabolized, get it peed out, do all that kind of stuff. You want to know when to intervene, give supportive care, and then when possible, give a specific antidote when there is one. So that gives you the new ABCDEs of toxicology, which are air, breathing, circulation, and now instead of disability, it's decontamination, and instead of exposure, it's elimination. And the F is find an antidote. This is why people like to tell jokes about emergency physicians. They say things like they don't seem to know the alphabet very far. Here, we get all the way up to F. Same in trauma. We get to the FAST exam. Beware of hypoglycemia, and you know this. Anyone who's got altered mental status, you should check a sugar. Because, I think it's pretty apparent why salicylates give you hypoglycemia, right? You're uncoupled, your metabolism's running like a car that's out of gear. So yeah, you might get hypoglycemic. But it's not intuitively obvious why acetaminophen will. except for the fact that the liver is sort of the gateway to all carbohydrate metabolism and it kills your liver. All right, insulin, I get that. Alcohol, alcohol can make you hypoglycemic if you're drinking hard alcohol, right, vodka, because 2 carbon fragments are not a diet. There's lots of calories there in alcohol, but you can't make sugar out of it. 2 plus 2 plus 2 equals 6. That sort of reaction exists, but only in plants. It's called photosynthesis. So unless your patients have leaves, they can't take alcohol and turn it into glucose. 3 plus 3 equals 6. That biochemistry you can do, that's called gluconeogenesis. Your liver knows how to do that. But 2 plus 2 plus 2, you can't do. So if you're living on vodka, you'll become hypoglycemic because you can't make sugar. So check a glucose. Oral hypoglycemics makes sense. Decontamination. So since the drugs had a head start, you oftentimes can't get them out. If I was to drink a bottle of vodka and 5 minutes later you were to try and come and make me empty my stomach to get it out, where would it be? In my bloodstream almost all already. It's super fast. You all know this. This is why after work a drink, makes you feel better like almost immediately. And then, it also won't benefit if it's non-toxic, and some of you, there are gray hairs in here. I know and I'm up there with you, coming up on my, whatever it is, 4th time on this. But we remember the days when we used to do charcoal, lavage, charcoal. Oh, that was just insane. We'd take a perfectly white room in the emergency room and turn it into a Dalmatian. And there was this sense, there was this belief that it was street justice. They'll never do that again. We'd put the E-wall down. Street justice. Turns out when they asked patients, that study was done, they asked patients, more than half of them didn't even remember that whole process and that struggle. So there's not even street justice in it. Who might theoretically benefit from decontamination? Early ingestions, a delayed release product, they can give you some sort of stories that might make it think. But by and large, we don't do a lot of this, and there's really nothing in the way of prospective studies that say this works. Syrup of Ipecac, kind of dead now. Anything that says syrup of Ipecac, that ain't the answer anymore. We just realized that when you give syrup of Ipecac, it makes them barf things that might help, like charcoal. And so we just don't do it anymore. There are a variety of contraindications. If someone's, way out in the middle of, Buffalo Park in the Northwestern Territories of Canada, maybe you would. But otherwise, remember, there was a time when every household had syrup of Ipecac, in the cabinet so that your mom could give it to you when, you got into something you shouldn't have. But we don't do that much anymore, and it's not recommended. Lavage, uncommonly used. Again, you might do it in a couple of situations. You might use a large bore, the E-walled tube, if there was things like plant material or stuff you need to get out of there. But remember that when you lavage, your big fears are going to screw up the airway. They're going to, vomit, aspirate, things like that. And so there are lots of problems with that. And that takes us to charcoal, which still works. There's a couple different types of charcoal. What's the difference between charcoal and superactivated charcoal? The superactivated charcoal is super. It's got about 10 times the absorptive surface area. So it actually is better, but you don't really need it. Dose, 1 to 2 grams per kilo, max 100. If you're using charcoal that comes with a cathartic, a lot of us have the premix, it's got sodium sulfate or one of those other things in it that makes them shit. Don't use the stuff that makes them shit repeatedly because they can get into problems with overactive gut motility and problems like that. So yes, you can use them for 1 dose, but after that you want to use plain old charcoal. And the worst thing that you can do with this is aspirate it. Charcoal works and will enhance elimination by binding some stuff, but it will really do it if they have enterohepatic circulation, where they pass the thing around their GI tract, and they're basically getting this concept of gut dialysis. And that happens with things like theophylline. That's why theophylline, we really invented theophylline not to make asthma better. Back in the day, we invented theophylline to justify toxicology fellowships. It was a great drug. It had enterohepatic circulation. It would be bound by charcoal. It had cardiotoxicity, neurotoxicity, unpredictability, bad level correlation. It was just like the poster child for a tox fellowship. Fortunately, now that it's gone away, I don't know if anyone's doing tox anymore, but there you go. What's poorly bound by charcoal? Lithium iron, so the heavy metals, caustics, cyanide, hydrocarbons, alcohols. Alcohols are just gone. They're in your system. Alkali and acid. Contraindications, ileus and obstruction, particularly if you're giving it with the cathartic, and avoid multiple doses of the cathartic, the sorbitol, the mag citrate, the sodium sulfate that they put in there. When would you use multi-dose charcoal? Anytime you were worried that this was a sustained release pattern, or it's got that enterohepatic circulation like theophylline, or it's got a lot of fecal elimination, like carbamazepine is like 30-40% fecal elimination, something like that. So while most drugs are, conjugated in the liver, peed out in the kidneys and things like that, there are a few drugs that have some fecal elimination, and that would be really helpul to make them go and have charcoal in their poop. And carbamazepine's the poster child for that. Charcoal hemoperfusion, you can do this for really tough intoxications that are protein bound or that you can't get rid of. It's not done that often because it's a bit of a pain in the ass to get set up and hard to do, but there are a couple places. Having noted that, whole bowel irrigation has a rising star. We're using it more often for a variety of things. It's more often being recommended for sustained release preps, for gastric bezors, for iron, lithium drug packers, lead, and the contraindications are pretty straightforward, ileus and obstruction. The favorite thing about ordering whole bowel irrigation, where they're going to have to go lightly in until it comes out the same color it goes in, clear out, is that'll get your nurses to find them a bed. Because that whole process of making them shit until it's clear does not sound appealing. There's nothing that will get you a bed faster than whole bowel irrigation orders on the chart. Misnomer of the month, you will do anything but go lightly if they put that in you. I mean, there's the other misnomer in medicine that I really like is skilled nursing. Those are the two big misnomers. I mean, at least when you work in an emergency room, as I told you, I work in the center of excellence of ground level fall and doesn't look good. They're all coming from skilled nursing facilities with like sodiums of 175. I mean, those people couldn't keep a succulent alive. That was fighting for its life, mind you. Somehow that succulent would fall off the window shelf. I don't know how it would happen. It'd be like ground level fall. That succulent could fall out of a wheelchair. I love the wheelchair slither, They go like some ribbon of pasta. They go down. You get ground level fall. You're like, out of the wheelchair? Yes, doctor. All right. Again, some of you are old enough to remember the days when we used to do things like for PCP, we used to give them vitamin C and we would acidify the urine in an attempt to do. There is no drug that we treat with acidification anymore. So if anything comes up on acidify the urine, just think, no, we don't do that. If anything comes up that talks about forced alkaline diuresis, again, something we did once upon a time. Nowadays, if you see that on a question, that's wrong. We don't do that anymore. We do some ion trapping with salicylates, but that is not forced alkaline diuresis. Those are different things, and there is no drug for which forced alkaline diuresis is recommended anymore. It's out of the picture. It's wrong. When you get to things like alkalinizing the urine and you're giving people bicarb and you're trying to get their urine pH up to 8, and it won't, a lot of times it's just like you're like, how much bicarb do I have to give this person? Their pH won't go up. What's the problem? The problem is you can't pee electricity. So for every HCO3 minus you want to go into the urine to alkalinize it, there's got to be something plus to go with it so that you're not peeing electricity. And so if the person's a little bit hypokalemic or hypomagnesic, the pluses that might go there, they won't do it because your body really thinks hypokalemia is life-threatening, and it thinks hypomagnesemia is even more life-threatening. So if you'd like to get the HCO3 minuses to go into the urine, you need to give more potassium or magnesium or both to get it to alkalinize. Hemodialysis, all kinds of things. One of the problems with hemodialysis is that your nephrology colleagues are really, really good at, kidney-related emergencies and nephritic syndrome, all this stuff, but they don't know jack shit about tox. And so when you tell them that they need to do dialysis for toxicology, they often just don't get it. And that it's really emergency, like they can't show up at their usual pace. Oh, we'll be down sometime later this afternoon. Yeah, no, come down. This is like an emergency. This person's getting clinically worse. Dialysis may save their life. Get here. You know, and you have to sometimes ask the renal fellow, like, when was the last time you had a chance to save someone's life? I'm not, you know, mostly what you do is make sure that the estate is completely empty so that there's no money left in it by dialyzing them forever. Today, you have a chance to save a life. Come on down. It'll be fun. But you have to get them there, and then you have to help them out with it because they often don't follow your recommendations. So for things like salicylates, lithium, and they always want to pretend like they know the level indications, which really is bad. Because remember that on the acute, on chronic, and the chronic overdoses, the levels don't matter. So they often misinterpret the need for dialysis based on the levels. So the lowly, poor first-floor emergency physician keeps talking about how shitty the patient looks, and they keep on yawning and saying, but the level's not that bad. No, stop talking levels, come down and do it. The levels don't matter when they look really bad and it's a dialyzable drug. Come down, hook them up. We'll talk later about why the levels don't matter. All right, low protein binding, low molecular weight, small volume of distribution. These are all things that, you know, they're in basically the water compartment of your body. Those are all really dialyzable. All right, so that's the intro of some basic things about tox. Now we're to the F of the primary surgery, A, B, C, D, E, F. Find an antidote. These two slides, this one, these blue and yellow slides, they're kind of gray and grayer in your notebook, are the antidotes. And I'm not going to go through them all. We're going to go through the drugs here in a moment. But this is the kind of thing, you know, that you look at before you go sit down in an exam, just to refresh yourself, short-term memory. I don't memorize this shit because what do I do when I got a bad overdose? It's the same thing you do. I call for help. I call the poison center. So why would I jam my head full of this bullshit? It's their job to know this. And so, but before an exam, for some of the basic ones, you know, the 10 or 15 overdoses that are common enough for you to know the antidotes to, this is worth looking at to review. So there's the second page of them, and we're going to talk about them. All right, now, really basic stuff. You get a tox thing. By the way, overdose, let's talk about overdoses. I already mentioned a bunch of them are suicides. Some of them are inadvertent. There's all kinds of stories behind them. The tox stories are always fascinating to hear. You should always want to cross-reference the tox story with someone else, with the pill bottle, with the pharmacy, because there's a lot of untruths there. And so when you ask about how reliable the story is, that actually has been looked at. So about half of overdose patients tell the truth. That means half lie. And of the ones that lie, they lie in both goddamn directions, which is really irritating. They both overstate how much they took and understate with about equal frequencies. And they often omit the parts that's really important, like, you know, the 10 grams of Tylenol. They admit that. Well, I took this and this and this. And there are a lot of times they're fairly random, the overdoses. I remember I was a resident when I saw this kid who overdosed on theophylline and Tegretol. It was perfect. He had a pretty bad theophylline overdose, but he was therapeutic on the Tegretol, so he didn't seize. So he was like he undid himself. He partially treated right at the same time. It was great. Now, in a tox question, they give you someone who took some shit, you know, took unknown substance, whatever it is, and they give you the electrolytes. They're telling you, please calculate if there's an anion gap or not. That's why they gave you the electrolytes. Electrolytes mean find out if there's an anion gap. And if they have an anion gap acidosis, you know it, it's mud piles. And let me just say it while we're on the tox section. Look at the I in mud piles. It's iron and INH and not isopropyl. You don't get an anion gap with isopropyl. All right. Yes, ethylene glycol? Yes. Isopropyl? No. No. So there they are, and they're pretty straightforward. So there's like going to be a mud piles question on pretty much every exam you'll see. There'll be one, maybe two. So that's pretty straightforward stuff, I think. Then there's the less straightforward thing, which is looking for the osmolar gap or the osmolal gap, where it's measured minus calculated. Here's how you calculate the serum osms: twice sodium, BUN over 2.8, glucose over 18, alcohol, and there people fight over what the alcohol number is, anywhere from 4 to 5. And if there's more osms in there than that, when you measure the osms, then you should be looking for what those are. And they might be another toxic alcohol, like isopropanol, methanol, ethylene glycol, or one of these other things. All right? So less of that. But the anion gap stuff, pretty straightforward. You can expect questions on that. Let's talk a little bit about tox screens. So there's the urine screen you get that just, has a, depending on where you work and which product you have, there's, second and third generation of these, even fourth now, I think. And, they give you a list of, the stuff that's out there on the street, to try and help you confirm. You should understand that those urine drug screens have lots of false negatives and lots of false positives. And by and large, you should identify the toxidrome that's before you and use such a one of these urine drug screens for drugs of abuse, street drugs, just to confirm. And if they disagree, right, the stuff that it's saying is there doesn't go with the toxidrome that's in front of you, stay with the toxidrome that's in front of you. That's the hard fact. The urine tests, these are largely useless. If you told me you were going to steal them from my emergency department, I couldn't have them anymore, I would be just fine with that. Here's some of the lists: false positives, false negatives. There's all kinds of stuff in there. Some of them we'll talk about more in detail. Fentanyl, right? And all the fentanyl drugs, they're tox screen negative. So for opiates, you'll see tox screen negative opiate deaths. That's to be expected with fentanyl and carfentanil. There's all kinds of other positives that are there and things like that. So just understand that they're very limited in their value. Have those urine screens got a little better over time as they've gone through a couple? Yeah, they have. They're still not great, though. Then we go to the place where you think you know what they took and a level might inform you. You're looking for a Tylenol level or acetaminophen level, whatever, rather than nail the drug manufacturer specifically for Tylenol. You want a acetaminophen level, or you want, a lithium level, or one of these things. Having taken poison center call, and I had a real toxicologist backing me up, when we got into levels, I almost always talk to the real toxicologist because people get the levels wrong. The levels misinform people about what they should do as often as they inform people about the correct thing. And the most common reason for this is they don't understand that the patient's got an acute on chronic ingestion, which means you can't use the level the same way. Right? Almost all the nomograms and stuff like that are about an acute one time, I pounded all the pills in the cabinet, and now let's see what I got. But they can really mislead you if it's not that pattern. So lithium's a real common one. They're on lithium chronically, but they took a bunch of it at one time. So they got a chronic level, and they got this acute superimposed, and so the levels are going to mislead you. Salicylates are another one where the levels are really misleading. And there's, so they used to say the level for dialysis was 120, then they said it was 100, then they said it was 80. And now we're back to a little more common sense-based thing. The indications for dialysis and salicylate overdoses, they look like shit. If they look bad, dialyze them. All right, now we're done with the intro. Now we do the 5 toxidromes, and these are really straightforward. You all know them. So I'm going to blitz, right? So anticholinergic, hot as hell, blind as a bat, dry as a bone, red as a beet, mad as a hatter, can't see, can't pee. You know it. They're pretty obvious, right? The anticholinergic one, the kid gets into the stuff, right? The autumnal high with the flower or the plant, right? They got eyeballs as big as saucers, 12 millimeter dilated pupils. They're giant. You can't miss it. And they're talking all kinds of shit. They're entertaining. Causes: antihistamines, atropine, tricyclics, anti-Parkinsonian drugs. There's Jimson weed. That's the autumnal high. Treatment: they can get seizures and agitation. You might try some benzos on that. If they're really whacked out of their mind, you can give them some physostigmine, which is, if they're acting delirious, you could give them a drug. What drug could be better named? Give them a milligram of antilirium. They're delirious? Give them antilirium. And it really works. People are hesitant to give physostigmine when they got a bad anticholinergic, and you really shouldn't be. It's really quite, there was some fear that it might cause some dysrhythmias. That's really not been proven to be such a big concern. If they get ventricular dysrhythmias because they're anticholinergic, you might try Lido or Amio. If they get torsade de poing, if suddenly they take a trip to France, and get a dysrhythmia, you can give them mag sulfate. And then anything they do you don't like in terms of wide complex tachycardias and things like that, just give them sodium bicarb. So that's kind of a useful slide for anticholinergics. And then they're going to show you here the difference between the anticholinergics and the sympathomimetic, right? They're both agitated, their pupils are dilated, their temperature's hot, and the skin is dry in anticholinergics and wet in sympathomimetics. It's sort of true. I find this a little bit of over-reliance on skin vital signs and stuff, but there you go. But you all know what the sympathomimetics are, and they're sort of different qualities, right? There's PCP. That means they threw a part of their bathroom at the cops. Only PCP does porcelainophobia, makes you rip a toilet out or the soap dish from your shower and throw it at the police. There's only one thing that does that, it's PCP. If they're super paranoid, freaky, and all that, you know it's methamphetamine. They got no teeth, they got meth mouth, right? They're doing that kind of stuff. It's methamphetamine. And the cocaine is the chest pain because of the vasal. I mean, you know them well. These are not strangers to your emergency room, and they should be straightforward. Causes: amphetamines, cocaine, PCP, ecstasy. PCP is one of the things they might ask you about, rotatory nystagmus. I don't know if you've ever seen that. It's really good. When you see someone with really good rotatory nystagmus, you'll want to shave their head and look for sixes because it really doesn't look normal when you see it. I remember a PCP, I was on the jail service on a post-welfare check, full moon gang sweep Friday. That's bad, just for the record. If you happen to be in the jail on any night, a post-welfare check, full moon gang sweep Friday is not the day to be there. So we were getting hammered, and I had two useless interns with me, and I was the R3, and I was behind, and I was doing stuff. That one of those useless interns became chair. Talk about fucking disasters. But anyway, so I'm hearing these like Tasmanian devil noises from the hallway, literally. And I'm thinking, oh God, we got a duster out there. I'm suturing some heads, doing stuff. And the duster manages to get the gurney vertically behind him. He was four-pointed and then some. So gurney now upright behind him. And he comes hopping into the emergency room from the hallway, promptly rips the sink off the wall, porcelainophobia, points the sink and the pipes at me, water spraying all over the place. And I'm like, turn to the entrance. That's PCP. Anyway, but that's all kind of PCP stuff. Rotary nystagmus, there you go. Treatment: benzos, and maybe more benzos after that with some fluids. Rule out rhabdo. Look for the, with all these sympathomimetics, they can get hyperthermia, rhabdo, and all the other things that you should be concerned about. All right, so we're 2 down of the toxidromes. Here's the third one, opiates. This is a real tough one. Pinpoint pupils, not breathing. Just in case you haven't noticed that, we're in the middle of this opiate epidemic that's out there. And I drive around Long Island, you see people out there going like this. In LA, if someone gives you, a hand sign, it's their gang affiliation. In Long Island, when they're going like this, they're giving you the Mallon symbol for the pill, the M's. Need some 30 milligram M's. This means they're selling them on the corner. You could pull up. Yeah, I'd like to overdose. I love the names for some of the more, we had a lady who, her husband, I don't know if it was husband, her significant other died of an opiate overdose the day before, and she was there, and then the next day she comes in with an opiate overdose. And he had taken tons and tons of Narcan to reverse, so we were thinking it might be carfentanil, which is the super potent veterinarian version of fentanyl. And so we asked her, we're like beginning to get on to her and treating her. She comes in, we're like, ma'am, are you using carfentanil? Did you have access to carfentanil? And she says, well, I had to look all over the house for it. It wasn't in there. I'm like, and? Well, it was in the glove compartment. I was like, of the car? She said, yes. I said, that doesn't make it carfentanil. Thank you, though, for that information. Anyway, so opiates, you're all familiar with it. You know what happens if you over-narcotize someone, they get the pinpoint pupils. You should be aware of the fact that some opiates, right, all opiates are not created equal. Some opiates do weird things. They'll give you dilated pupils and agitation. So in general, it's the small pupils and they're not ventilating. But some, like a Dilaudid overdose, a Demerol overdose, a diphenoxylate overdose, even dextromethorphan overdose, I call them the Ds. Those are 4D opiates that all give dilated pupils, agitation, and seizures. So if you only recognize opiate overdoses that are pinpoint pupil, somnolence, and hypoventilation, you'll miss some. causes, there you have them all. And remember that the Narcan has a shorter half-life than some of the drugs you're talking about. Propoxyphene, there's another one that causes agitation and seizures. And it's still on the D list because it's Darvon. Still on the D list. So that would be the 5th D of the dilated pupils and agitation on the opiate list. Okay, clonidine can mimic a heroin OD or an opiate OD, right, with the pinpoint pupils and the hypoventilation and the sedation. Treatment, Narcan, start low dose because they're not very nice. You don't ever really want to hard reverse them because they're not nice when they wake up. And there are other really more important reasons aside from their personality disorders that you don't want to hard reverse them. If they have cocaine and heroin together and you reverse the heroin, then you have unopposed cocaine with Narcan. That's bad, right? The Narcan has a little bit of adrenergic release, so now I got cocaine with a catechol. That's bad. You're asking for VTAC, VFib, problems. So that's another reason not to hard reverse them. You don't want to hard reverse them if it's something like, the difenoxin, the Lomotil overdose, because then you're going to end up with the opiate reversed, and you're going to have Narcan, which is again a little bit of a goose to their adrenergic system, plus atropine. Now you're going to have a heart rate of 200 because the unopposed atropine. So there are some combinations which you should respect that are commonly out there that are reasons not to hard reverse an opiate. If you've reversed them and they go back down, they might need to be redosed, and there's all kinds of stuff. Is it safe to let one of these people go who's refusing further treatment after reversal? Different states have different laws regarding your ability to confine them, and New York basically says if they have any wisp of competence, you can let them go after that. What are some of the ways that letting an opiate overdose goes wrong? One, they resedate because they had a longer lasting one. That's usually not that big a problem. They'll be brought back. Most times they'll be found and brought back. It doesn't happen that often. But the biggest reason is you didn't take enough time to figure out that, yeah, they were an opiate overdose, but what they took was Percocet. So the problem is that if you want to take enough Percocet to have pinpoint pupils and stop breathing, that's a lethal Tylenol overdose. So now you let someone go with a lethal and treatable overdose. So you want to look for that. All right, cholinergic, sludge, salivation, lacrimation, urination, diarrhea, gastrointestinal upset, and emesis, plus the killer bees, bradycardia, bronchospasm, bronchorrhea. They always ask questions about how much atropine should you give them. They ask you, should you give it up until they stop urinating? Give them atropine until the urination stops. No, who cares if they're peeing? Give them enough atropine until the diarrhea stops. Yeah, the nurses want you to do that. But that's not when you stop. You stop when the killer bees are stopped, when the bronchorrhea, bradycardia, and respiratory distress associated with those is over. So you give atropine titrated to the killer bees. You don't care about the sludge. No one dies of sludge. People die of the killer bees. The nicotinic effects and the muscarinic effects. The nicotinic effects are the muscle weakness and the fasciculations and respiratory failure. What are the causes? Organophosphates. And there's been some, there was a rebirth of those questions because these were possible terrorist agents and chemical warfare agents, so they wanted us to know about them. And there's all this stuff about getting serum red cell, plasma red cell levels and intracellular red cell levels of this. Again, that's a mess. They won't ask that. Treatment, atropine plus 2-PAM. Treat until the secretions are dry. All right, so we're almost done with the toxidromes. We're to withdrawal syndromes, alcohol, barbs, benzos. Remember, no one dies of opiate withdrawal, even though they wish they would, and many people die of opiate overdose. No one dies of a benzo overdose, unless they choke to death on the pills, unless they get an airway problem. No one dies of a benzo overdose, but the withdrawal pattern is potentially lethal. So sedative hypnotic withdrawal is lethal. Opiate withdrawal is uncomfortable. So keep those straight. And, you'll see people nowadays, there's a lot of Xanax and stuff out there. There's a lot of alternate benzos. Xanax is particularly ragged in withdrawal. It's a suburban abuse drug that's really ragged and nasty in withdrawal. So withdrawal syndromes are things we see and deal with, and you should respect sedative hypnotic overdoses because they are potentially lethal. And alcohol withdrawal gets worse and worse and worse until it gets to the DTs, There you have the label of the beer, the DT's beers. And to have DTs, delirium tremens, you need to have more than D and T. This is a diagnosis that is misused a lot. There are multiple definitions out there of the DTs, but to have the DTs, you got to have delirium tremor and dysautonomia manifested by hypertension, tachycardia, and a fever. That's one of the definitions out there. And I could take 100 charts that say the patient has DTs, and just by looking at the vital signs, the patient has no fever, they don't meet the criterion. So we overuse DTs. You could say severe withdrawal, impending DTs, that would be correct. But to call them DTs, if you say DTs, admit medical ward, that's wrong. The whole definition of DTs was to identify a population of withdrawal patients that needed to be in the ICU because they might have vasomotor collapse. So DTs means no ward. DT means admit ICU because they're at risk for dying. We do the same thing, by the way, with thyrotoxicosis and thyroid storm. Thyroid storm was defined in a way to identify those patients, and they have to have a fever for storm, was identified people who needed to be in the ICU because they might die. So thyroid storm and DTs are disease entities that were specifically defined to identify an ICU population at risk for death from their problem. Both of them require you to have a fever, and in both disease entities, it's a sloppy definition because they might have other reasons for a fever. How many alcohol withdrawal patients have you seen who might have pneumonia or aspiration or a cellulitis where you can't tell where the fever is coming from? It's a sloppy definition, I got it. But it is what it is. All right, now we get to acetaminophen. We are at the part of this talk where we start at A, and it already sounds horrible, and get to Z, going through all the drugs. Obviously, we're not going to do the whole PDR. We're going to do sort of the common ones. And the most common one of all is acetaminophen. And we could stop acetaminophen overdoses in this country anytime we wanted. They did it in all other countries. They decreased the number of people on their liver transplant list by half in the UK, Italy, Benelux countries. And how did they do that? They just said you can't sell acetaminophen in more than 7 grams at a time, and it has to be in a blister pack. Now, in the United States, that's too much of an impingement on your personal freedoms. You need to be able to back a pickup truck up to Costco, use a forklift to get a 150-gallon drum of fucking Tylenol at less than a half penny a tablet, bring it home, and store it in your house where someone can overdose on this. And that's why we keep half of our liver transplant list loaded down with acetaminophen overdoses, where the cure is demonstrated and proven in like a dozen other countries. But we can't figure it out enough here in the United States. We're such fucking geniuses to do the same thing. Now, I'm going to do this. Last time I did this, someone thought it was really misogynistic. So I don't mean it to be that way at all. But women do overdose more than men, particularly in suicide. I will do my example of an overdose, and I mean no misogyny whatsoever. So there's a fight at home. She stands up, "You're such an asshole." She goes to the bathroom. She opens up the cabinet and takes what's in there. It's not really well planned. Like I say, the kid that I talked about, he took the Tegretol and the Theophylline, and they canceled each other out. They take whatever's in there. Now, if there's a huge jar of Tylenol in there, if there's the blister pack in there, like, "I hate you, motherfucker," they throw that away. They don't take them anymore because they can't get to them because they're pissed. This is not a rational thing, and this is how these overdoses happen. And the blister pack is super effective at preventing it. Now, if you also said to me, Dr. Mallon, you loser, half toxicologist, poison control, taking call loser, you could only have one level, I'd be all right. I want the Tylenol level. I want the acetaminophen level. Because it's super common, it's out there, and it has sneakiness to it. We'll go through that in a minute. You know, if you hang out with your toxicologist, they'll tell you in the livers there's the 3 metabolic pathways that go down, and the middle metabolic pathway goes to the toxic intermediate, and you should be able to say, if you want to hang out with your toxicology friends, you got to say, "Yeah, let's go get some NAPKI." You know, you get the NAPKI is the toxic free radical. You see it down there at the bottom, and that's what causes the hepatocellular toxicity. And here's the important thing. Here's what it looks like. Early on, you overdose, and usually they're drunk at the time, right? This is how it is. And they might have some GI symptoms, but then they get better. They're still potentially a treatable lethal overdose, but they look pretty good. So an overdose that's super common has a silent period while it's still treatable by the antidote. That's the level I want. If you were going to tell me I could only have one level, that's the level I want. So remember, they may ask you on the exam the sort of 4-hour rule. If you were going to get a level, you'd like to know when time 0 is, and then you check the level at 4 hours, and if it was greater than 140, they get 140. That used to be the mnemonic for it. If it was the level's greater than 140, they get 140 mg per kg of NAC, and then you go from there. Now we mostly do it IV, right, which is a shorter protocol. That's the main reason we've chosen IV. Because giving it orally is great, right? It goes right to the target organ. If you give the antidote orally, it goes straight to the portal system and into the liver. There could be no, this is an overdose for which oral administration is perfect. But it takes that protocol, the oral NAC protocol, takes 72 hours. And no one wants one of these patients in their emergency room that long. So we'd like to do the shorter one. So we do these IV a lot. Safe in pregnancy, you should still give it in late presentations because nothing else is going to save them, and they're going to go on to liver transplantation if it's bad. And here's the nomogram. Remember, it's only for acute overdoses, and there are lots of acute on chronic ones that may be worse at lower levels. So again, don't be fooled by the serum levels when someone has both acute and chronic going on. And there's the NAC. And NAC is used for other things besides Tylenol. I remember I had a patient recently who was taking the dysuria, over-the-counter dysuria meds, the azole, is that what it's called? One of those, that for urinary symptoms. And I saw her, and she had pyelo, and everything was boiling out to pyelo, but she kept vomiting, and I was like, what's with that? So I got her liver functions, and they were symmetrically bumped, 1,000 each. And I was like, So I started asking more about the azole, and she had taken a lot of it, because the dysuria was just torturing her. And so I called the poison center, and no, they said, absolutely, this is something that you would treat with N-acetylcysteine, and so she should be admitted and put on that. And I was like, really? But the thing I remember the most was the way he told me that. So I called him back. I'm like, these are liver functions. Here's where we're at. Here's how much she took. I said, and so there's this pause, and the guy at the poison center in New York said, "Knack her up." I'm like, what? You said, give her NAC. I'm like, oh, okay. I'm on it. We're on it. We'll follow the orders. And off we did. So there are other things besides Tylenol that get treated where you need to restore reductive potential of your liver so it can continue doing safe metabolism. All right, now we're to the next most common overdose in the emergency room. Well, probably not the next most. The Tylenol and acetaminophen are common and treatable. Alcohol is really, really common. And we see both withdrawal and intoxication. We see a lot of trauma. It's always interesting to see on the exams what's the biggest cause of death related to alcohol ingestion. And they have things like liver failure and varices. It's anyone who's worked even 10 minutes on a Saturday night in an emergency room knows it's trauma, 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 and trauma. And then it's 2 more traumas before any of those other medical causes of death even begin to end. About every single way you can die, if you were to do that book or that movie, 1,000 Ways to Die, alcohol would be in with every one. You look at farm deaths, you might think, oh, that pastoral living, it's so clean, the fresh air, eating the natural vegetables. They're fucking hammered all the time. When they flip the tractor, they're drunk. So about half of all farm deaths are alcohol-related. I know, I grew up on a farm in Western Mass. There's nothing good about being on a farm in the middle of January. You'll be hammered too. You can look at like boating stuff, half of those fatalities. You can look at violent crime, almost every way you can die, alcohol's in there. So it's trauma is the way they die. And occasionally they die of alcohol withdrawal and other things. We got the DTs there and giving them the thiamine and the B vitamin. Wernicke's and Korsakoff. So Wernicke's is still out there and people don't recognize it. So remember, it's oculomotor paralysis or dysfunction, cranial nerve 6 palsy, nystagmus, ataxia, and global confusion. You'll see patients that have this, and remember that when you give them a banana bag, if you do that with 100 milligrams of thiamine in it, that's only to prevent them from getting Wernicke's. If they have Wernicke's, that is not enough to treat them. If they are confused and can't follow commands and can't get up and walk because they're ataxic and can't move their eyes, they need gram amounts of pyridoxine. And when you order, and I've had lots of people, I remember a guy who I was stopped by the residents to look at him because his stomach was in his chest on the chest x-ray, and like, what do you think of that? And I was like, all right, it looks like his stomach went through his chest. He probably had a diaphragmatic hernia. Does he have any scars? The residents looked at me like, why would he? You know, scars? I'm like, that would have been associated with that. They're like, oh yeah, we'll go look. And then I was like, well, what's going on with him anyway? Why don't you just ask him? Well, he's altered. And so I go there. The guy has every peripheral manifestation of chronic alcohol as you can imagine. He had a rhinophyma bigger than Carl Malden's. He had cherries. He had everything. All of those are there. And I was like, well, they're like, well, his electrolytes are normal, CAT scans normal, all this stuff is normal. So I said, did you try giving him some B vitamins? And they're like, So anyway, after we got to around 600 milligrams, because it's usually 500 to 1,000, the guy sat bolt upright. We said, what happened here? He goes, a kraut got me in the big one. WW2, that's from a bayonet. That's how awake he became. This is a guy who hadn't said a word in 4 hours in the emergency room. Adequate doses of B vitamins, he woke right up. So don't forget, Wernicke's is out there. But it's gram amounts of B1. When you order pyridoxine in high volumes, that's B6, or thiamine in high amounts, it's shocking what happens in almost every hospital I've ever worked in. The pharmacist has like seizures, like you've asked for plutonium or polonium. They ask, you want the water-soluble B vitamins? And those, that's a toxic amount, doctor. I'm like, what are you talking about? There's no B vitamin toxicity. They'll PB vitamins. But anyway, it's always amazing when you ask for a gram of B1, they'll act like you're like a big B vitamin theft suspect. All right, now we get into the toxic alcohols. These are kind of important. They're fair game. There have been a bunch of methanol overdoses all around the world with bad hooch, so you got to pay attention to it. They get wicked bad. There's a little bit of my Massachusetts. They get wicked bad acidosis. You've all seen a million DKAers over your career, and they all have bicarbs of 5, 7. That's what a bad DKAer with a pH is, even 7, 6, 9 has. When you see bicarb 0, doesn't happen often. That's methanol. There's not many things that give you bicarb 0. Severe acidosis, the acidosis from the formaldehyde being formed, they might have visual changes and blindness, they might get pancreatitis, and they might seize. So it's kind of CNS and eye stuff. The bottoms, on these toxic alcohols, the bottom of the slide gives you the clinical stuff that you need. Treatment, 4-methylpyrazole and ethanol and dialysis. Remember, if it's a bad toxic alcohol, the 4-MP, right, they're going to ask you about the 4-MP. I'm fine with the 4-MP, but you need to understand that might just be a temporizing move while you get to dialysis. They may yet need dialysis. Don't think of the 4-MP as the final die cast on this. I got some more. Ethylene glycol, the antifreeze, the solvents, the coloring in it is added so that you know it's there. They get an anion gap acidosis, right? It's on the mud piles. They get an increased osmolar gap. So if you did the calculation versus the measured, right, it would be off. They get oxalic acid crystals in the urine, the envelopes, and it causes acidosis and hematuria, renal stuff. It's all renal stuff. Crystals, hematuria, it's all renal stuff. As opposed to the methanol, which is I can't see, neuro stuff, seizures, severe acidosis. And now treatment here, 4-methylpyrazole, again, the 4-MP. Bicarbonate if they need it for acidosis, and again, dialysis. All of the toxic alcohols, if they're bad, even if you see a frat boy, so you see some frat boy come in who's got, and I remember I saw one once with an alcohol level of we called it the Vegas level. His level was 777. He was intubated, we were having trouble, his pressures were dropping, we were doing all the supportive care stuff. We dialyzed him. So even a regular old alcohol overdose that's bad enough, alcohol, it's beyond intoxication at that point. What the chart should say is alcohol poisoning. But when they have alcohol poisoning, it's the same thing. You dialyze. Any of these look bad, they get dialysis. Any of these alcohols look bad. So dialysis of severe acidosis are bad clinical finding. And then finally you get the rubby, right? There's rubbies and rummies. Rummies are people who are on the, on the street drinking a lot of rum. And the rubbies are desperate who are drinking rubbing alcohol. And they had to take all those hand washers, right, the foam ones that you have in your hospital, out of the jails, right? Why? Because there's alcohol in those. So people are withdrawn from alcohol, drink that shit like crazy. What's Pruno? Pruno is the alcohol they make for themselves in jail because they're withdrawn. You take the prunes, You take some tap water. You take some of that white bread that's on the cafeteria line. That's your yeast. You put those together in a plastic bag. You put it somewhere warm for a few days. Let it ferment. Then you strain it through your drim shocks and drink. I've tasted it. It is horrible. Horrible, horrible, beyond belief. But if you were withdrawing bad, you'd do it. But anyway, so when people are withdrawing, they'll do anything to treat their withdrawal. If there's no alcohol around, they'll drink rubbing alcohol. They'll do mouthwash. They'll do NyQuil. They'll do ginseng, right? Those little ginseng things you see at that little Chinese thing. Oh, get the healthy ginseng. They're a quarter alcohol. That's like a small shot of alcohol. The kids all know that because they mix it with their Vicks Formula 44 when they're doing their skittling. They know they can get that alcohol without an ID. All right. So rubbies, ketosis but not acidosis. The yellow box is the key. Normal anion gap, as I said, in the anion gap acidosis, isopropyl is not there. And then you have your toxicities in increasing order at the bottom. All right. No, we haven't left A yet. All right, amphetamines. We all know what that looks like. Sympathomimetic, hypertension, tachycardia. Amphetamines, how do these people die? Well, some of them die of strokes and hypertensive-related things. A lot of them die of trauma. So if you were to take cocaine and amphetamine and compare them, in amphetamine, 2/3 die of trauma, 1/3 die of the drug. So a lot more trauma, because you know how paranoid they are and how the cops are involved and all that stuff. 2/3 die of trauma, 1/3 die of drug. As opposed to cocaine, 2/3 die of drug, 1/3 die of trauma, and that's because with cocaine there's so much vasospasm, so you can get cardiac and CNS problems related to it. Remember that beta blockers are contraindicated. If you've ever seen that YouTube of the guy who is on the table and they give a beta blocker to, who's a cocaine chest pain, and watch his vessels go like this. There's a beautiful YouTube of a guy on the table who gets a beta blocker in the cath lab for cocaine chest pain, and all you have to do is watch like 5 seconds of that YouTube. You're like, don't give them beta blockers. Diane mentioned this. It's a good one. Cocaine associated with abruptio placenta and prematurity. We've all seen rhabdo, strokes, MI, status, all things related with cocaine. Here's the MI associated with. What's the incidence of cocaine causing MIs? You'll see numbers all over the dartboard from around 1% to some. There was a Philly study that said up to 25, 30%. Most people who see a lot of cocaine in an urban inner city ER where there's a lot of crack cocaine and things like that, think the incidence is really pretty low, in the 1-2% range. That this idea that it's 25, 30% is a little bit cray-cray. So yes, can it happen? Yes, it's vasospastic. Sure. If they inadvertently took their own beta blocker that they're on for, their hypertension afterwards, sure. Antabuse reaction, pretty rare, an uncommon thing. They love it on exams, though. So alcohol plus Flagyl will give it to you, as well as the, Disulfiram, and it can be pretty bad. You'll see hypotensive people flushed, puking, headache, seizures. It can be pretty bad. I've had to admit people for this. The question will always invariably say, a young woman who saw her gynecologist recently, that they're trying to get to the Flagyl. So that's code for on Flagyl. Arsenic and some heavy metals. I don't think they'll ask a lot of heavy metals, but here's a picture of, the arsenic findings with the nail changes, and the treatment is chelation. They get neuro and gastroenteritis kind of things. Barbs. The old days, probably again, some of you in here remember the days of seeing barb blisters. I certainly do. When you'd see these people who are out so hard that they were barb blisters, but they still had some ventilation, so they didn't die. So they were brought in with these barb blisters. And there's short-acting and long-acting ones, and they can get these cutaneous bulla, and the treatment is lavage, charcoal, alkalinization for the long-acting ones only, for phenobarb in particular, and hemodialysis. Don't see a lot of barbs anymore. Benzos, see lots of them. Remember, flumazenil, relatively contraindicated because the person with a benzo overdose is probably a chronic benzo abuser. And as I said, the benzo withdrawal syndrome is potentially lethal. So the last thing you want to do is give flumazenil and take a non-lethal overdose and turn it into a lethal withdrawal pattern. So no flumazenil for these. All right, what causes most of the overdose deaths? If you go to the Poison Control Center data, and you want to talk about non-drugs of abuse, right? So we're away from the heroin and all of that, which we've been in the middle of this epidemic of. But if you go away from those drugs of abuse, the vast majority of deaths are beta blockers and calcium channel blockers, with the calcium channel blockers leading the way. A lot of times it's PEDs, where they get into 1 or 2 tablets. These are really at the top of the list. 1 or 2 tablets could kill you. There was that landmark paper, I bet all of you remember it and have heard some lecture about it, where they go through the list of 1 or 2 tablets will kill you if you're a child, overdose list. And these are on there. The antidotes, glucagon 5 to 10, it often doesn't work. Insulin and dextrose, and then nowadays we're going with intralipid. Again, you'd have to call your pharmacy. I don't think they'd ask for a lot of detail on how this is given. And that you just need to know that intralipid is one of the options. I think that's the detail we're talking about. You could try atropine, it doesn't work. You could try vasopressors, they often don't work. You could try a pacemaker, which frustratingly often doesn't work. And the other thing that you might try with these is ECMO, or as I like to call it, resuscitative ECMO, because if this is a young, healthy person with a couple of tablets of a beta blocker in them who's going to die, all I need to do is give them extracorporeal membrane oxygenation for a couple of days and let their liver catch up, and then they'll be better. And so RECMO is resuscitative extracorporeal membrane oxygenation. People talk a lot about it in cardiac arrest and things. Overdoses are a totally valid reason to play the ECMO game. Totally valid reason. And then don't forget the timolol eye drops. I see this missed all the time. Someone comes in bradycardic, and everyone says, well, they got sick sinus syndrome, blah, 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 get the card, blah, 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 put in a cordis so they can float the pacemaker, blah, blah, blah. And I go, they're on any beta blockers? And they say, no. And I go up to them, I look at this old person, when was the last time you saw your eye doctor? I say, well, about a month ago. What, did they put you on some new drops? Yep, where are they? Timolol. So timolol eye drops, well-known cause of significant bradycardia, well-known cause of worsening CHF. Remember that, as you become specialized, you know what emergency physicians say about specialists, right? A specialist is someone who knows more and more about less and less until they know everything about nothing. So from the ophthalmologist specialty standpoint, all they really know is that the heart pumps the blood to the eyes. And so it doesn't occur to them that the timolol, which could affect the heart, isn't going to do so well with it. So timolol eye drops are higher potency than you think. It's common treatment for chronic open-angle glaucoma. So don't forget, when someone has a beta blocker or bradycardia kind of thing, because it'd be a shame if they got a pacemaker when really they should just be taken off the timolol drops. And so that's out there. Now we go to the calcium channel blockers, very similar stuff, bradycardia, hypertension, conduction delays. Does this look familiar? So we start with the calcium gluconate to get by the calcium, the calcium channel blockage. We're going to try and do that. Then we do all the same things that we did for the beta blockers. Glucagon, insulin, glucose, intralipid. You could again do ECMO, and these overdoses are really, when you're faced with a kid or a young adult with a calcium channel overdose or a beta blocker overdose, they're really frustrating. Because a lot of the things you might try, the fluids, the pacer, the vasopressors, the supportive care, you think you have all the stuff you need to support them. It doesn't work. They need to get this stuff out of their system. Now, I said earlier that all those patients who arrive alive to the emergency department with an overdose of some kind, less than 1% die. And that's true. That doesn't mean you can't die by overdosing. There are lots of successful suicide overdoses. They're not coming to the emergency room because they're found dead. And among those, top of the list is carbon monoxide. So it's a real common cause of intentional suicide, but it happens accidentally as well. Carbon monoxide, they always ask these questions. It shifts the oxyhemoglobin dissociation curve to the left. That's bad, right? Your hemoglobin's super smart. Oh, I'm over. I'm going to break there. Your hemoglobin will end with the idea of how smart your hemoglobin is. Remember, you got a lot of it in you. That makes you really smart.